We'd like to demonstrate for you today the anatomy of the meniscus and a few key points about meniscus transplantation. First, the meniscus must arrive frozen, non-irradiated, with the meniscus tibial attachments all the way around the periphery intact. Must be frozen in order to preserve the tissue, must not be irradiated because irradiation severely damages the thin leaflet of the medial and lateral meniscus. And it must be attached all the way around the periphery because those peripheral attachments are what the surgeon will use to stabilize the meniscus to the tibial plateau upon insertion. This is a meniscus transplant case where we've received both the medial and the lateral meniscus transplant attached to the tibial plateau, which is the way we prefer to receive them, and I'll explain that in more detail. We soak the received tissue in alcohol for 5 minutes if it has not been treated with a wash process, and for 1 minute if it has been treated. The role of the alcohol is to remove the contamination that may or may not have occurred at the time of harvest. After 5 minutes in alcohol, we'll soak it in a bacitracin solution to finish defrosting the tissue. And we'll soak this just until the tissue is soft enough to dissect. So the meniscus is received ideally on the tibial plateau like this. And the reason that this is ideal is it's very important to understand the meniscus anatomy. First, we'll focus on the medial meniscus. The medial meniscus sits on the top of the tibial plateau and inserts very variably over the front of the tibial plateau. In this particular cadaver, you can see there's no coverage on the anterior aspect of the tibia. The meniscus sits way forward. Sometimes we'll find them inserting here and sometimes way down the tibial plateau. The meniscus has an intermeniscal ligament which connects often the medial and the lateral meniscus. In this particular cadaver, it's not particularly prominent, but it would hide underneath this tissue, although sometimes it stands up as a separate layer of tissue. Most importantly, the meniscus on the medial side inserts on the tibial plateau through the peripheral meniscal tibial ligaments. This skirt has actually never been formally named to my knowledge, but this is the important attachments here along the tibial plateau, here along the side of the tibia. If the surgeon sews the meniscus to the capsule when doing a meniscus repair or when doing a meniscus transplantation, it sucks the meniscus out like this and produces what we call pseudo-subluxation or shrinkage. So shrinkage is very commonly the result of sewing the meniscus tight to the capsule and pulling the meniscus off the tibial plateau. It's very important to try to anchor the meniscus to the tibia and to the tibial plateau back here in the corner and at the horns, so that when the knee flexes and extends, the meniscus can ride and rotate appropriately on the tibial plateau. So if a bank sends you the meniscus stripped of its peripheral attachments, it's very difficult to have any tissue remaining to sew to the periphery, and therefore you'll suck the meniscus out, which is not ideal. So if we look at our harvest for the meniscus, first of all, another important point to notice is that the posterior horn of the medial meniscus inserts right here underneath the PCL and very much over the back side of the tibial spine. So when the surgeon is looking from the anterior aspect of the joint, it's very easy to make the mistake of putting the drill hole for the new meniscus too far anterior and pulling the meniscus tissue forward. This will lead to a posterior horn medial meniscus tear. So the guide and the drill hole for inserting the posterior horn in the meniscus must be way down the posterior slope of the tibial plateau. Lastly, when sewing the meniscus in, it's very important to get the posterior horn quite far posterior, and again, if possible, attached to the tibia and not to the capsule of the joint primarily. So when we dissect off the medial meniscus in preparation for transplantation, what we do is lift up the meniscus horn and reach down underneath it, capturing a sliver of the periosteum for the anterior horn insertion, and we capture part of the meniscal tibial attachments. This will become the insertion site for the new meniscus. And notice on this cadaver, it's way anterior to the tibial plateau over a fairly wide footprint. So this is where we want to put it back into the new recipient. Then what we do is come around and come underneath the meniscus, trimming the attachments, but leaving a skirt of the meniscus tissue so that we can sew this back to the recipient and not dislocate the meniscus out of the joint. So here we've freed the meniscus from its meniscal tibial attachments all the way around the back side. And what we'll do is we'll place our suture in the anterior horn. Now notice that the meniscus tissue itself stops here and the meniscal tibial attachment extends past it. So since we're going to drill a drill hole in this location on the patient who receives this new meniscus, we want to preserve this attachment so we can dunk this into the hole, leaving the meniscus free to migrate a little bit on the tibial plateau. So I leave this skirt of tissue attached. Anteriorly it has a little layer of periosteum. I don't tend to use a bone block at the anterior horn of the meniscus. We place resorbable sutures in a weave type fashion in order to secure this anterior part. I usually will start within the tissue that I want to have dunked into the hole, weave our way up through the meniscus itself, and then back down again. Note that all the sutures we use are resorbable, as we don't see any reason to leave permanent materials in the joint when we're doing a biologic reconstruction of the joint itself. The absence of artificial materials diminishes the chance of an irritation at a later date. So here we provided a secure knot in order to dunk the meniscus into the tunnel that we're about to drill. In this case, I'll put an extra loop through the top so it can come over the top and dunk it down. And then if necessary, we can trim a little excess here so it won't get caught into the hole. Then what we do is we come around the back of the meniscus, and so here we've retained a fair amount of the skirt of the meniscus. Hold out to the side. Now, based on how much meniscus tissue the patient has left, so if a patient has a pretty good rim of meniscus left, I won't leave very much skirt of the meniscus. If the patient has got almost nothing left, then we want to save this tissue so that our sutures grab both the meniscus and the peripheral tissue and sew that into the attachment. So in this case, we're going to leave a little skirt coming around the back here, and I'll tend to leave a little bit more right at the back corner where I know my drill hole, my third drill hole through the, we call the third tunnel, will capture this tissue and anchor it to the back of the tibial plateau like that. So now, as we look at the attachments of the medial meniscus, notice that the meniscus posterior horn attaches right down here in this broad groove. You can see it very nicely. See it very nicely on this plateau where the articular cartilage is here and drops right off into a nice trough for this posterior horn of the meniscus. So we have now shifted to using a bone block in order to insert this posterior horn into that trough on the recipient. The way we do that is we take an oscillating saw, and my plan here is to leave just a little fragment of bone on the meniscal tibial attachment. So we can see, so here's the posterior horn of the meniscus, here's the meniscus horn itself, and here's its bony attachments right there. We'll clean this up a little bit, and the object is to have some bone to fixate in the new tunnel of the new meniscus. Now notice notice how broad the posterior horn meniscal insertion really is. So we don't want to have a pinpoint insertion there or one way back here. We'd like to have it settle in the joint so that it can rotate on the tibial plateau in a more normal fashion. Now we'll place our posterior corner stitch, which we've measured the distance between our drill hole for our posterior horn and our drill hole for our posterior corner. Again, the reason for this third tunnel is to anchor this part of the tissue to the tibial plateau, and also to secure this fragile area here, which is very high risk for posterior horn meniscal tears. So we do that. We measure the distance with a calibrated probe. So we measure from our hole over to our third tunnel, which in this patient will be just about right here, just before the wide part of the meniscus. We'll go ahead and place these sutures. Anchored our back spot to go right down our posterior tunnel. So here it will anchor the meniscal tibial ligaments without pulling the meniscus off the joint. And lastly, we'll place our posterior horn stitch. We'll shape this posterior spot to fit down our 7mm drill for the posterior horn of the meniscus. Here we'll capture the meniscus tissue as well as the bony tissue. So these sutures, when they pull down the hole, will pull the bone block down with it. So just to remind you, the tunnels that we've drilled are the hole at the front for the anterior horn is a 7mm drill hole that will dunk the anterior horn into. It's a 7mm drill hole for the posterior horn that this bone block and posterior horn of the medial meniscus will dunk into. And then it is a 4.5mm drill hole for the third tunnel at the posterior corner. Before we pull the meniscus into the joint, we flip it over and paint the bottom with what we call Walgenbach lines, after Nurse Ann Walgenbach, who 20 years ago told me to do this so we could tell the top and the bottom apart. This is a tibial plateau for the lateral meniscus transplant. It comes frozen. We soaked it in alcohol for 5 minutes and then a bacitracin wash until it defrosted. Notice that on the lateral meniscus, the horns insert quite closely on a little bony bridge. And the importance of the bony bridge here is that as weight bearing occurs on the lateral meniscus and the meniscus pushes out to the side, the circumferential hoop stresses are preserved if the bridge and attachments are normal. If the attachments are abnormal, the hoop stretches will be quite abnormal, and the force going through the lateral joint will not be correct. Also notice that the lateral meniscus is hypermobile compared to the medial meniscus. It rotates quite a bit on the tibial plateau. So it's very important that the meniscal tibial attachments, the attachments of the meniscus to the tibia on the periphery, are preserved as much as possible so that these attachments can be anchored to the tibial plateau, permitting the meniscus itself to rotate. If the surgeon sews the meniscus too tightly into the capsule, the meniscus will not rotate properly on the tibial plateau and subsequently tear. The most vulnerable part of the lateral meniscus transplant is the zone between the posterior horn insertion and the popliteus. This area can be easily torn when the patient's knee rotates back if this is not secured to the tibia. Additionally, if this is inserted a little bit too anterior, as the femur rolls back on the tibia, it will tear the lateral meniscus. So the most important thing to check in your post-op MRI, and we always do a day one post-op MRI to check the position of the meniscus, is to make sure that this posterior horn is truly posterior on the back of the tibial plateau and not placed too far anteriorly. Next, we'll go ahead and dissect the meniscus. So here, notice in this, if we lift it up a little bit, the attachments of the periphery of the meniscus to the tibial plateau. These are the important attachments that permit the meniscus to rotate and to stay affixed to the tibia. So we preserve these and we place our sutures in them when sewing in the meniscus. So now what we want to do is create a bony bridge that's going to fit the trough that we've made in the recipient's knee. And so notice how close the horns are. So we just want to have a bony bridge going from here to here in order to insert in the recipient. So we start on the most lateral side. So we dissect away part of the PCL here. We look at the Acl insertion and notice how the anterior horn of the lateral meniscus inserts directly at the ACL. And so when placing the lateral meniscus into the knee, you can line up your forward and back position, your AP position, by the placement or the anatomy, the insertion of the ACL. We can take a large osteotome. Notice on the tibial plateau how much the posterior part slopes back. So it's very important that when placing the meniscus third tunnel, that it's not up here on the tibial plateau, but far down the back, so that the meniscus can insert here on the posterior aspect of the plateau and then rotate appropriately. One of the reasons why we believe we see tears of the posterior horn of the lateral meniscus is because the surgeon fixes it here where it looks like it's the back of the meniscus when looking through the front with a scope, when in fact the tibia slopes down dramatically, and it's way down here is where the fixation point needs to be. From this view, you can see the very steep posterior slope of the tibial plateau on the lateral side. The plateau is convex rather than being concave. So the meniscus at the posterior aspect of it, the meniscal tibial attachments are way down here. A common error is to place the posterior drill hole here on the tibial plateau, which will lead to a tear of the posterior horn of the lateral meniscus. It's very important that when placing the meniscus into the knee, that the bone block be far enough posterior on the plateau so that the meniscus can rotate all the way back. If it's placed anterior on the plateau, the posterior horn of the meniscus will tear. We measure the distance from our posterior tunnel to our posterior 1/3. In this case, 3 probes lengths apart. So we're just about right here is where our posterior third tunnel is. We've left a considerable amount of meniscal posterior tissue here, maybe a little bit too much in this setting, so that the strong part of the tissue can still be inserted posteriorly. Here, the posterior aspect of the meniscus can insert down in the tunnel at the back of the joint. For the bone blocks, we go ahead and place one for the posterior one, and we notice that the cartilage surface we can poke a needle right through without breaking the bone block. And so that gives us a way to anchor the suture. We can do that for the anterior one as well. Then when we bring the meniscus to the knee joint, we pass our looping suture up through this posterior corner stitch, to the posterior stitch, and to the anterior stitch. And then we pass a pull-through stitch here at the middle of the meniscus. Now notice it will pull the lateral meniscus transplant in through an anterior medial portal on the knee, which pulls the meniscus right across the knee joint and permits the bone block to fall into the slot, like that. Again, most important that this be pushed back in the slot so that it fits posteriorly and anatomically in the joint. It's very helpful to have slotted cannulas so that when placing this mid pull-out stitch, you can place the stitch and remove the cannula before you place the meniscus into the knee joint. Note that because we have excellent attachment of the bone block and this posterior corner stitch, we generally do not need to use any all-inside devices to secure the meniscus, because we can reach all the way around the periphery with an inside-out technique. A few instruments that are particularly helpful in doing meniscal transplantation is first this AO guide that we've rounded the tip of so that we don't scratch the cartilage when we come in the knee. We use this guide in order to release the deep fibers of the collateral ligaments by doing a Singer sewing technique in and out like this, which creates both bleeding in the periphery and releases the deep fibers of the ligaments so that the knee joint can be opened a little bit more and permit insertion of the lateral and medial meniscus. For placing our drill holes, we use a custom-made guide that we designed in order to have the curvature match the shape of the femoral condyle and therefore not damage the femoral condyle, and a spoon in order to catch the drill pin as it comes through the knee and diminish the chances of it going through the back of the knee. We use this drill guide for the posterior hole, for the anterior hole, and for the posterior 1/3 hole. So notice that on the lateral side, when we place our drill pins, we place the first one posterior in the trough that we've made. The second drill hole is placed the posterior quarter back here down the tibial slope of the knee, and it's most important that the drill guide be placed all the way down on the tibial plateau so that the meniscal tibial ligaments will be attached low and not high. And then the third hole is drilled in the anterior aspect of the lateral meniscus trough. For the medial meniscus transplant, we place our guide, our custom designed guide with a curvature to protect the femur here posteriorly on the tibial plateau so that we're behind the tibial spine and exiting out off the back of the articular cartilage margin. This will permit the new meniscus to be pulled into the slot created by this drill hole posteriorly. We drill our posterior corner tunnel at just before the wide part of the posterior medial aspect of the tibial plateau, and this secures this at-risk corner at the back of the medial meniscus so that it pulls the meniscus tissue down into this back corner. For the anterior horn on the medial meniscus, we use a straight AO guide, which we bring through the anterior portal and place directly on the insertion site for that knee. Now notice that the insertion site is over the anterior margin of the articular cartilage. So this hole will be placed with a pin, a 7mm drill, and then to bring a tunnel up to it, we use a traditional triangular poodoo guide placed into the hole and drilled up to that spot so that we can bring the sutures of the anterior horn of the meniscus down the hole and insert it in that location. Rehab for the meniscus transplantation procedure varies based on the status of the articular cartilage. If the articular cartilage is in good condition, then the lateral meniscus, when it's transplanted, the patient can be rehabilitated in full extension with partial weight bearing, because in full extension, the lateral meniscus is stable in its insertion. And so we permit partial weight bearing in full extension for 6 weeks with out-of-brace range of motion exercises. For the medial meniscus, we permit partial weight bearing in full extension as well, because the meniscus again is stable in full extension, but with flexion tends to rotate. And so we permit partial, depending on the status of the articular cartilage, if the articular cartilage is in good condition, we permit partial weight bearing in full extension. If the articular cartilage is damaged, and we've done an articular cartilage pace graft to repair the damaged cartilage, then we'll use a short arc CPM if we do the repair simultaneous with a meniscus transplantation. If there's extensive articular cartilage damage, we will do the articular cartilage pace graft to repair the tibia and the femur first, and then 6 weeks later come back in a second procedure and replace the meniscus. If the knee is globally unstable, missing its ACL, its articular cartilage, and its meniscus, we'll do the ACL reconstruction with the articular cartilage pace grafting in one step, and then 6 weeks later, after the patient has regained their full range of motion and used a CPM machine, we'll place the new meniscus cartilage.